for inviting me to this talk, and I must acknowledge Professor Marvard that I met in Kenya in January 2020, and I also must acknowledge involvement in spreading the knowledge of electrophysiology throughout the African continent and in the sub-region. I also acknowledge my colleagues online, Amy Bonney, David Bradley, who is on a sabbatical from University of Michigan in Rwanda, and also, sorry, I think I might have, and Mohamed Jalen from Nairobi. This morning, I'm going to talk about the topic of ventricular arrhythmias and sudden death, and I'm just going to highlight certain topics that perhaps may be of interest to me personally, and it's difficult to cover the full gamut of sudden death and ventricular arrhythmias in the time allotted. I do not have any significant conflict with this topic here. Ventricular arrhythmia and sudden death, we have to kind of understand certain definitions. In most situations when we talk about ventricular arrhythmias, it can be something as basic and benign as people having premature ventricular ectopy or PVCs, and to something that progresses to malignant arrhythmias. The challenges we have is that it's often difficult to predict when this transition will happen. And for most intents and purposes, sudden cardiac arrest is defined as sudden cessation of cardiac activity where the victim becomes unresponsive and there is no evidence of normal breathing and no signs of circulation. And if there are no interventions implemented, we will not, that person will subsequently die. This slide here is just from the latest version of the Heart Rhythm Society American College of Cardiology guideline on sudden death prevention. And I must acknowledge Sana Al-Khatib, who was a resident when I was a fellow at Duke, and also Professor Ann Curtis here in the audience, who were on the writing committee on this topic in the United States. But when the issue that we have, why it's such a challenge, is that when you look at the total numbers of people who will die suddenly, they belong to the general population that we do not have any good way to risk stratify them. The people that we know that have arrhythmia risk markers, like people who have had previous myocardial infarction with a reduced ejection fraction, or people who have survived previous cardiac arrest, they represent a smaller fraction of the total number of people who will die suddenly. So it behooves us to be able to find certain risk markers that will help us to identify this other individual, and there's still a lot of ongoing work in this effort. I will start by one of the most common, the commonest ventricular arrhythmia you will see, which are premature ventricular ectopy or premature ventricular contractions. They're often benign, and they may be present in up to 30% of people. It can be aggravated by certain catecholamine stimulation, like use of drinking excessive caffeine, certain over-the-counter cold medicines, and they're often asymptomatic. But the concern we have is that some of these PVCs may increase cardiac risk and mortality, and they may sometimes trigger the development of a cardiomyopathy. And there are certain types of PVCs that may be what we call short-coupled PVCs that may trigger people to go into malignant ventricular arrhythmias. And that's often defined as a coupling interval less than 300 milliseconds, and most of these PVCs have a not too wide, not too narrow duration, about less than 130 milliseconds. In people with a heart that is structurally normal, often we define that by the use of echocardiogram for most intents and purposes, but we know from multiple recent MRI studies that many of the patients that we label as structurally normal may have abnormalities that are undetected by standard 2D echocardiogram and that we may be able to identify on MRI, such as areas of focal myocarditis or fibrosis. And the other issue is that most of these PVCs have a focal origin, And the mechanism is not due to re-entry, which is the commonest mechanism of some of the sustained arrhythmias we deal with. Most of these are due to triggered activity or abnormal automaticity. And these PVCs in general are catecholamine sensitive. They may sometimes be worsened by exercise, and as I mentioned, by excessive adrenergic stimulation. And most of them arise from the region of the outflow tract, and they respond to isoproterenol and exercise testing. I just showed this here from where a patient came to us just about 2 weeks ago who was having ventricular ectopy, and his ID is from what the physicians described. As you can see, the ventricular ectopy occurred here, and all of a sudden it developed into a more malignant arrhythmia. And this is the example of how these PVCs can trigger ventricular arrhythmias. And as we demonstrated about over 20 plus years ago, that these PVCs are amenable to ablation and being able to eliminate malignant arrhythmias in many of these patients. And so, what else do we need to worry about PVCs? PVCs can lead to development of tachycardia-induced cardiomyopathy, which is a little bit different from the general mechanism of when we talk about tachycardia-induced cardiomyopathy, which is due to a rapid rate in atrial fibrillation and in people commonly with a arrhythmia called PGRT. But the PVCs-induced cardiomyopathy is associated with the degree of PVC burden. And there is a component that certain hemodynamic derangements that occur because of the PVC can lead to ventricular desynchrony. And some of the underlying mechanism relates to calcium handling rather than inflammation or mitochondrial oxidative phosphorylation, which we have seen in patients with other mechanisms of tachycardia-induced cardiomyopathy. And the underlying mechanism is abnormal calcium-induced calcium release from the sarcoplasmic reticulum, which disrupts the excitation-contraction complex and myocyte contractility. Some of the risk factors that we know can contribute to development of PVC-induced cardiomyopathy is a component of what we call a non-ejecting PVC, where the PVC does not result in generating a measurable systolic arterial pressure, generally less than 5 millimeters of mercury. And as we know, when you're trying to check the pulse rate or you check by the automated blood pressure recording, the patient may be alarmed that my heart rate is too slow. So this is a concept of concealed mechanical bradycardia, secondary to reduced cardiac output. Some of these PVCs also may result in post-extrasystolic potentiation, where there is more than a 5 millimeter mercury increase in systolic blood pressure following the following sinus beat. And these PVCs can cause calcium overload and increase myocardial oxygen consumption. Other risk factors is the fact that some of these patients do not have any symptoms, and it's possible for these PVCs to have been ongoing for many years, and this may result in an increased likelihood of developing a cardiomyopathy. And in those who have symptoms, if the symptom duration has been more than 30 months, there is a good chance they may develop a cardiomyopathy. We know the male sex, for some reason, has a contribution. And sometimes you can detect those who will develop this cardiomyopathy by certain echocardiogram imaging techniques using speckle tracking, which may detect occult disease in patients with frequent PVCs and so-called normal healthy systolic function at the current time. And the association of fatigue has been known to increase the likelihood of developing cardiomyopathy. And this is due to the fact that the PVCs result in increased wall stress in patients with high PVC burden and normal LV systolic function. Some of the electrophysiological criteria include a high PVC burden, generally more than 20% of QRS complexes. And when the PVC QRS duration is more than 150 milliseconds, or if the PVCs are arising from an epicardial origin or are interpolated PVCs.
Recording stopped.
Most pure PVCs induced cardiomyopathy generally will improve after 4 months following an ablation. And the goal of the ablation is that we should have an 80% reduction in the PVC burden. Likewise, if we use medications, the goal is that we should reduce the burden of PVCs by 80%, and that should result most likely in improvement in the function. But there are some people who will not improve. You may know this up front because sometimes you want to be able to be very proactive in how you monitor those patients, because if they represent a subgroup that may not improve, you may want to have a closer follow-up and maybe consider them for primary prevention ICD and additional treatment for reduced ejection fraction in the future. That's people who have a baseline PVCs less than 17%, which tells you that most likely the PVC might not have been the cause. And the broader QRS duration of the PVC more than 170 milliseconds, or people who have epicardial PVCs may not likely respond to therapy. And also if they have a bundle branch block already at baseline, or a very dilated left ventricle more than 63 millimeters at baseline will be important criteria. And also when we are in the EP lab and we're doing an electrophysiologic procedure, and if these patients have a unipolar voltage amplitude less than 8.2 millivolts, likely represent areas of diffuse fibrosis, and there is a lower chance they may respond. In those people that we expect their ventricle to improve, the presence of post-extrasystolic potentiation is associated with recovery, and absence of scar on MRI imaging is important, and those with a large unipolar voltage during mapping in the EP lab is an important criteria. This is just an example from our lab where you see this is an outflow tract PVC on the left side. We generally will use, like you use here, we tend to use a Cato frequently. We use Navix as well, and some we use another company called Arhythmias by Boston. We do what we call the pace mapping, and we use intracardiac echo just to define coronary anatomy, and usually these PVCs will go away from that. The other topic to discuss is that of ventricular tachycardia. For most in the audience, sustained VT is generally defined as VT lasting more than 30 seconds or required termination due to hemodynamic compromise if it's of shorter duration. And non-sustained VT is anything more than 3 beats in a row. Monomorphic VT is when the QRS morphology is stable from beat to beat. And polymorphic VT is when there's changing of multiform QRS morphology on the tracing. And bidirectional VT is when the QRS frontal plane axis changes from beat to beat. And to start the point is a form of polymorphic VT associated with prolonged QT. And by and large, the most predictable and reliable way to prevent sudden death in patients with high risk for cardiac ventricular arrhythmias is the use of an ICD. But we know that ICDs in most communities in the United States, we use a lot of primary prevention ICDs. And some of this has come under debate recently because what we see is that the absolute mortality reduction with the primary prevention ICD is about 5.8 to 7.9% over 2 to 3 years. And a lot of emphasis has been made on the relative risk reduction. And this brings us to the point that the number needed to treat to save one life is 13 to 17 ICDs over 34 months. But when it comes to the question of the secondary prevention ICD, the benefit is much clearer. And it's, of course, it's stronger because these are people who have already demonstrated a risk profile. And so the number, the mortality reduction in that setting is approaching 27%, and the number needed to treat is less than 10 patients over 36 months to save one life. The other issue is that in a lot of these patients who have ICDs, especially in the ischemic cardiomyopathy population, the amount of scar tissue they have on their cardiac MRI can predict those who will likely benefit from use of the ICD, as shown in this slide here, whereby the scar burden greater than 16.7 grams resulted in a higher likelihood of appropriate ICD therapy within 30 months. And this slide here just depicts some of the recent concerns we've all faced around the world, whereby, as you know, as a result of the COVID pandemic, this was during the Paris lockdown, that you can see there is a definitely increased risk of mortality during the pandemic, during the weeks when Paris was under lockdown, and this was kind of clearly shown. We don't know whether all this is due to ventricular arrhythmia. Some of this mortality might have been due to complications from COVID. And this is just that during the pandemic, we have a reduced response time. We wrote about some of this in the United States as well, because as the pandemic was raging, EMS were more reluctant to respond, and the use of bystander CPR significantly declined during that time. And when we are in the procedure room, these are some of the concerns. Most of the VT ablation that we do is for ventricular tachycardia storm, and these are some of the risk factors that may portend the likelihood of having a challenging case or procedural outcome. People with more advanced heart failure, and the number of VTs induced, and generally if you have to do shocks, and as you can see, sometimes some of these procedures can be long. But in people that you are successful with this procedure, ablation definitely affects survival in people who have a very low ejection fraction. And in some of these patients, I just jumped to this to discuss some of the more recent work. And over the last 10 years, maybe longer, we've been doing a lot of epicardial VT ablations. And there are some criteria that you will use in defining those who will likely have an epicardial circuit: the presence of a pseudo-delta wave, an intrinsic deflection time that is longer than 85 milliseconds, and the shortest RS complex duration in any precordial lead more than 121 milliseconds. And people with non-ischemic cardiomyopathy with Q waves in the inferior leads. And this is a video. Basically, what we show here is that these patients are very sick. We use a combination of intracardiac echo, as well as image fusion from our fluoroscopy equipment to gain access through the subcostal space, and you can see the wire going in, and we inject dye. We superimpose this on the image. In our lab, we always shoot a coronary angiogram at the time of epicardial ablation. We were using CT fusion images in the past, but sometimes trying to register that images and having reliable image fusion is being a challenge, so we prefer to just do a cardiac catheterization on the EP lab. And we use a multipolar mapping techniques to map the surface of the heart and the endocardium. And so we just map both. We've done an endocardial map before this point. For some of these VTs, it's very difficult to induce and map during sustained VT. Most of what we do is really substrate modification, whereby you kind of dechannel, what we call it dechanneling procedure. You identify different electrogram characteristics that will help you identify the areas. And sometimes you can achieve non-inducibility, but that can be a challenge. But definitely there is reduced PVC burden. But I put this slide up because I've talked about sudden death prevention and ventricular arrhythmias. But I think one of the areas, especially when I looked at in Africa, where it's very difficult for most people to afford the cost of a defibrillator, one of the emphases that we have seen also in the part of the United States where I live in Georgia is that when you have population that are dispersed, you have to rely on community AED and people learning CPR. We've done this event. We started a foundation about 13 years ago where we put AEDs in different communities. Brianna leads that effort for us now. We train coaches in the high school. And our goal is that every student that will graduate high school in our community should know how to use an AED and perform CPR. But we have even moved it lower, that from the age of 10 years old, we're training a lot of the children to use an AED and to do CPR. And we have remarkable stories of classmates that have saved each other. They have saved their teacher or at a parents' event. And in association with that, we do a 5K run. And we have one coming up November 5th. I have to get back to the United States and start training because I've gained some weight since I've come to Egypt. But that's basically what we do and where we train all the coaches. And this has been very useful. We also partnered with these are members of the Denver Broncos. That's a football team. A gentleman was from our community who plays on that team, and he brings his team down to help us, motivate the young people. They will come and listen to a sports star. So I know in Egypt, soccer is big here, or what we call football. I think partnering with athletes, prominent athletes is useful. But the main essence of this talk today is that PVCs are quite benign and common. Beta blockers and non-dihydropyridine calcium channel blockers will be the first line of treatment. And high-risk PVCs can be associated with sudden death and development of cardiomyopathy. We know that ablative therapies are quite useful for PVCs and idiopathic VT. And in the setting of ischemia and non-ischemic cardiomyopathy, in people with high arrhythmia burden, these procedures can be life-saving and preserving. I must remind everyone that ICD therapy remains